طيب بسم الله الرحمن الرحيم. I think we should start now to stick to time. First, the Egyptian Society of Cardiology would like to welcome all of our colleagues, all the audience from everywhere. Actually, we started this series 1 week ago, and we are planning to arrange a series of 8 webinars on this subject. The subject is the paper, the position statement paper that has been published by the Egyptian Society of Cardiology about the management of cardiac patients during the COVID-19 pandemic in Egypt. We know this difficult time, many hospitals have been allocated to isolation for COVID-19 patients, and many of the services of cardiology that has been normally offered to cardiology or cardiac patients have been reduced or downgraded. No elective procedure being offered to our patients. Many patients even suffering from acute coronary syndrome or acute heart failure visiting the ER. Maybe they are afraid from the COVID-19. So we are trying to make a balance between giving our cardiac patients the best care that they deserve, at the same time protect our medical staff and protect also the patients from getting the infection or the spread of infection. This is the balance that we are aiming at during in this paper and during this series of webinars. We had, as I've told you, 2 webinars before, and this is the 3rd webinar. And in this webinar, we have actually 2 eminent speakers. The first one is my dear friend, Professor Mohamad Marwan. Marwan was a friend of us in Ain Shams University, and he went to Germany, and he became one of the most knowledgeable experts in CT scan. That's why we have the privilege and the honor to have him as a speaker in this regard. And also I would like to welcome a new field, Professor Ahmed Osman, who is an assistant professor of radiology in Ain Shams University. And thank you, Ahmed, for joining us despite this short notice. And it's very good to have this radiological or radiologist perspective in comparison to what our cardiology colleague will tell us. So it's good to have both kind of views. And let me welcome 2 of my great friends. Actually, they will be the moderators of this great webinar. Professor Islam Shawky, treasurer of the Egyptian Society of Cardiology and professor of cardiology in Al-Azhar University, a very eminent figure in CT. And I think, again, he will lead the discussion and will introduce the speakers. And also, I have my dear friend, Professor Amr El Hadidy, board member of the Egyptian Society of Cardiology and professor of critical care medicine and cardiology in Cairo University. So now I will leave the floor for the mic for both my dear friends, the moderators, who will introduce the subject and the speakers. Thank you. Professor Islam.
Bismillah ar-Rahman ar-Rahim. First of all, I would like to thank Professor Dr. Sameh Shaheen for this series of webinars, actually, which is marvelously arranged, and I got amazed, everybody, when we see this schedule. We got amazed how Dr. Sameh in this very short time arranged such excellent presentations and webinars, and he asked too many figures from everywhere in the world, not only from Egypt, from Europe, also in this very short time. Maybe this one of the benefits of virtual learning, that we are easily can ask such a professor like Dr. Marwan to share with us in very short time, rather than working on this for weeks to have him here in Egypt. Dr. Marwan is, as Dr. Sameh said, he's well-known figure, not only in Egypt, but I think now worldwide in cardiac CT. Dr. Marwan, born and graduated from Ain Shams University, is now working as associate professor of internal medicine and cardiology. He's a director of cardiac CT lab in Erlangen. And for those who doesn't know Erlangen, Erlangen is considered, I usually say it's like Mecca of cardiac CT. So everybody, maybe in Egypt at least, and in too many places worldwide, to work in cardiac CT, he should visit Erlangen. I had this opportunity back in 2014 when I visited Dr. Marwan and spent a lovely 3 weeks over there. I gained some experience in CT, and Germany, they won the World Cup at this time, 2014. So it's a privilege and honor to welcome you, Dr. Marwan, and I'm sure 100% that everybody watching this will benefit from your presentation, cardiac CT in the era of COVID-19. Dr. Marwan.
Shukran Kazilan. Thank you very much for the lovely introduction. It is an honor and a pleasure to join and share some opinion, and at least my personal opinion. And gratefully, I have to say, I asked some colleagues who run high-volume cardiac CT centers all over the world from different countries to share their opinions as well, and would be happy to give you a little bit of a feeling how things are dealt with in different parts of the world, especially that most of the centers have no real experience in this pandemic issue, and a lot of decisions had to be made on spot, ad hoc, and that's why we will see that different centers have dealt with a strategy a little bit differently all through the last couple of weeks. Let me share my screen first. I hope this works. Okay, so I was asked to talk about cardiac CT in the era of COVID-19 and would like to share some insights, some important considerations, and what is, out of my perspective, sensible use, which is the most important issue in such times, especially in countries where the medical facilities are suffering or are not able to or doesn't have the capacity to accommodate the numbers of the sick patients. I think two main things or two main issues have to be discussed in those COVID times: some strategic thinking and some aspects of what cardiac CT can do. And I think those two main topics are the decisive points how CT or how cardiac CT, and later on our colleague from the radiology perspective will share his opinion as well as far as the lung CT perspective is concerned. I'm talking about cardiac CT. Strategic thinking, we need to think about the personnel safety, which is extremely important, in the exposure when doing CTs, the issue of rapid discharge and clarification of symptoms, the issue of trying to avoid admissions, saving beds, as well as reducing the risk of infections, and of course, the question about what to do about elective exams. So this is one part of it, is the strategic thinking around the pandemic time, and of course, how can we use the ability, or what can cardiac CT really do in a very well-fashioned and in a very accurate way, which is reliably excluding coronary artery disease, assessing patients with low-risk acute coronary syndrome, patients with chest pain at the emergency room, and providing volumetric information with assessment of structural changes. And this is an important aspect of using this imaging modality, sometimes to avoid transesophageal echocardiography in certain populations, in certain questions. So these are some of the points I would like to share with you over the next coming slides. So two issues: what CT can really do in a good fashion, and how can we use that to have a safe exposure of the personnel, to rapidly discharge patients, to avoid admissions, and how to deal with elective exams. And I think, as previously said, every country different parts of the world, and even in the same country, different decisions have been taken. So there's not really right and wrong. It really depends on how you can deal with this setting. One important issue is the hospital setting, which does change the management or does change the strategic decisions as far as exams, whatever kind of exam, if it's imaging, if it's intervention is concerned. So in our hospital setting, actually, these are a couple of the images I had yesterday, just to give you a feeling of how things are dealt here. We have the advantage or the nice thing of having a completely dedicated CT scanner for corona patients, for COVID patients. You can see here, this is corona CT, and actually both rooms or both CT suites are more or less opposite to each other. So this is the one for the COVID-19 patients or the suspicion of COVID-19, and the room is sort of has advantage of having a control room for the technicians, and they have access to this control room from this side, from my side. And if you look through the glass window here, this is a relatively high-end scanner. It's not the best at what we have in the hospital, but it's a scanner that can do cardiac or has a cardiac package. And this room here has an entrance for outpatients, but usually the suspicion of COVID or the COVID positive usually come from the ward. And you can see here behind this door is another door for the access of the patients that are usually accompanied by nurses, by ward nurses or nurses from the emergency room that are already equipped with personal protective equipment. And the technicians and the radiology technicians as well as the doctors are sitting outside. So this is a nice way to save resources. So the nurses come with the patients. They do help with putting the patient on the bed, and sometimes they also, if they need contrast, they can connect the contrast pump, and that way we have less exposure of the personnel. The nurses are already equipped. They do take care of the patients on the ward, or they take care of the patients in the emergency room, so they can do that. Usually wait outside in a special room, and then they take the patient again. So it's sort of saving time and saving and less exposure. And we have a different CT. It's on the opposite side. It's a so-called clean CT or non-COVID CT, which is where we do our daily cardiac CT scans as well as other radiological scans. So we do share the scanner with the radiology department. And this, of course, gives us some flexibility as far as elective exams are concerned. So we have a clean CT and a completely dedicated COVID-19 CT. The setting is important because accordingly, depending on the hospital or the practice where the images are done, maybe this would change some aspects or some administrative aspects. So as far as elective exams, we generally had lower numbers of patients because at the beginning of the COVID wave in Europe, we did downregulate in the entire hospital any elective procedures to free intensive care beds, and this included as well our outpatient clinics. So outpatient clinics were suspended, and accordingly, generally, we had much lower numbers for CT, but also for other exams, for echoes, and so on. Patients who already had appointments were informed that the CT scans could still be performed, but we did extra send them letters, or we talked to them, and that we understand potential fears of coming into the hospital, especially for elderly, and we could reschedule. So this option was given. As said, we had a dedicated scanner for non-COVID patients, so this was more or less a little bit flexible. And we did continue with the TAVI program in the hospital because these are patients waiting for the procedures. Some of them are not doing well, heart failure patients. So the TAVI program continued, and it would have been difficult because it was not expected when the end of the wave would be. So to catch up with all those numbers, it would have been difficult, especially within the TAVI program. So CT for the structural planning for the TAVI procedures was continued as well. So the hospital setting allowed us a little bit of flexibility as far as cardiac CTs, but we did have much lower numbers, but we did not actively postpone cases. What CT can reliably do, there are some slides. Maybe some of the colleagues joining the webinar are not into cardiac CT or not have that much experience with cardiac CT. Over the last 20 years, it has been clearly showed in different studies that CT can very accurately show us the coronary anatomy, including coronary wall with the atherosclerosis. And now we have lots of studies. This is just a meta-analysis of 30 studies over 3,700 patients looking at the diagnostic power of cardiac CT compared, of course, to the invasive gold standard. And we can see that the true positive rate or the sensitivity is very high with a little bit of less specificity. So we have a very high diagnostic accuracy of this modality, which means the sensitivity is high. We can detect disease. And if the CT says it's a normal CT angiography, we can extremely rely on this information. So it's a reliable rule out of disease and no further workup is required. And of course, this was one of the main reasons this CT in the diagnostic workup of the chronic coronary syndromes, or what previously was chronic stable coronary artery disease, as a class 1 indication, along with other non-invasive functional imaging modalities. So it's a class 1 in clarification of chest pain in those patients within the stable setting. And we can see that the workup of the chronic coronary syndrome or the stable disease is a little bit complex. We have different numbers of modalities that could be used according to expertise and according to different factors. And we can see here some preferential factors that may push the decision a little bit more to CT. I will just make it a little bit bigger for everybody to see. So preferentially, coronary CT angiography would be considered in patients with low clinical likelihood, if we're expecting that they would not have obstructive disease, so low clinical test, pretest likelihood. Patient characteristics suggest high image quality, and a very important factor if we have a patient who's extremely obese, is a non-sinus rhythm, he cannot follow breathing commands. So those patients, you might as well, from the beginning, send them to a different modality. It's important to pick the right imaging or the right clarification modality for the right patient. Local expertise and availability is extremely important. If you have a good nuclear guy, send them to the nuclear guy. If you have a good CT expert, then maybe it is the right modality in this setting. And if we want to know information on atherosclerosis, no history of disease, these are factors that would rather speak for a cardiac CT for clarification. But actually, if you look into the details of the guidelines, so this table here shows the clinical likelihood of significant coronary artery disease in the coronary angiography. 0 is the low likelihood, and going to 100 is the high likelihood. So if you can look at the CT in the ability of ruling in, which is red, or ruling out, which is green, of coronary artery disease, even in rather intermediate and the high intermediate or higher likelihood, CT does really perform quite well in ruling in and ruling out. So we have a little bit of more flexibility of using it. Now back to the CT in the context of the COVID pandemic, especially in the emergency room setting, we know that CT could be used as an alternative to invasive angiography to exclude acute coronary syndromes when there is a low to intermediate likelihood of disease and the cardiac troponins and or ECG are inconclusive. It's a class 2A indication. And I think even with patients with a little bit of positive troponin within this COVID context, if the clinical suspicion or the clinical picture does not really go into the area of obstructive coronary disease, then the use of CT in this setting, in the emergency room setting, to rapidly discharge those patients or clarify those patients is very appealing. And the idea is to have a clear and a rapid and a direct risk stratification, because we have the coronaries on spot. Patients who have nothing at all, they need nothing, sent back home. Patients with atherosclerosis, we might discuss some drugs, but these are clearly to be discharged from the emergency room. And patients with obstructive disease, this is the right coronary artery here with a mid obstructive lesion, then these needs further workup and maybe revascularization. This should be or could be discussed according to the risk profile of the patient. So the idea of using CT in this context, especially with those issue of COVID in the background is to rapidly discharge those patients from the emergency room. And I think the thinking generally, especially after the ischemia trial, so the post-ischemia trial, and put on top of them the COVID era, probably you've heard about the ischemia trial, which randomized over 5,000 patients to either a conservative strategy, which is optimal medical treatment initially, or initial invasive strategy, and then looked at a primary composite outcome of cardiovascular death and myocardial infarctions and hospitalization, and a very specific thing to this ischemia trial that patients had to have at least moderate to severe ischemia, non-invasive testing, and most of the patients had left main disease excluded with CT, I think about 73%. So left main disease was excluded, and non-obstructive disease, which was defined at a threshold of 50%. So less than 50% in CT, these patients were excluded from the trial, and the rest were included. So they wanted to be sure that they're not randomizing left main to medical treatment. And you can see with the curves, and you heard that the outcome was similar after a median follow-up of 3.2 years. So there is a lot of discussion about the ischemia trial, and a lot of issues. Maybe the randomization was not, or the randomizing modality looking for ischemia was not the right factor, especially that patients with the highest ischemia had the lowest events. I don't want to go into details of this trial, but the idea is if you don't have left main disease, then your outcome on optimal medical treatment, even if you have obstructive disease, in this ischemia profile patient, which are patients, specific patients that are not severely symptomatic, that don't have heart failure, that don't have reduced ejection fraction. So the idea is if you have in CT, you could exclude in CT left main disease, then your prognosis or your outcome is quite good. And this kind of information, especially with the COVID time, could be a way of risk stratifying patients and guiding, or potentially guiding, the time of admission for PCI. So this is one way of thinking, but probably will change our thinking about patients after this trial a little bit, and especially within the context of the pandemic. An important issue, and the next coming slides I usually have them in a lot of my presentations because these are relevant issues, which is image quality. These are realistic images that we see every once in a while. We see it everywhere. We see it in Germany, we see it in Europe, we see it in the States, we see it in Egypt. So it's not specific to certain countries. If you perform the acquisition in a bad manner, you're expecting to have poor image quality, which more or less 100% translates into a false positive or a wrong result. One clear image here, this should be the LED with the very poor image quality. You might think there's a stenosis here in the LED. Another image with not very nice image quality, but even more, a lot of calcium here. And this is the sort of prototype of a false positive. So actually there's no significant stenosis in this left main LED segment. So image quality is decisive. And this is one scan that actually have been performed here in Germany in a center that is non-experienced. You can clearly see the same patient, heart rate controlled, nitrates given, breath hold, and you can see the difference. The LED is completely normal. So image quality is quite important. And I'm mentioning that because in the context of the COVID patients, this was a clinical scenario we had here. A nurse that was positive for COVID-19 had severe LV dysfunction. Maybe the video just worked for a couple of seconds, so the LV functions are quite poor, and they wanted to have the coronary status checked, especially that she would be sent for a CT for the chest as well. So those patients usually are not doing very well. The breathing is not very good. The heart rate is not optimal. So the general setting is not uncommonly suboptimal in those COVID patients. You can see the heart rate is around 90, so sinus tachycardia. The patient have to have surgical mask to avoid droplet infection and so on. And you can see the images here of the LED is not very nice. It was just sufficient to exclude relevant disease of the proximal segments, but otherwise some of those patients would be really suboptimal for a coronary CT. This is one important thing: which patient that could be adequately examined with CT. And we're seeing the other way around. And I mean by that, patients who are sent for a cardiac CT or receive a cardiac CT, then we have some findings in the lungs. One example here, a 72-year-old gentleman who had a CABG operation 1 year ago, actually. He had 4 grafts, and you can nicely see them in the 3D reconstruction. It's only just to show you that what kind of grafts he had, and they are all patent, so you can see them. They're not occluded. He had exertional angina, and that was the reason for the cardiac CT. So the cardiac CT showed that the grafts are patent. This is the graft going to the RCA. This is the native RCA calcified. This is the graft to the RCA. And if you look here, just zoom in a little bit, there's a clear anastomotic high-grade stenosis of the RCA graft to the native RCA, and this explains his angina. But we do look at the lungs in the cardiac CT. We have a segment of the lung, and the radiologists, our colleagues, have a look on the lungs, and they have this peripheral area here of the left lung, and it's zoomed out a little bit. So they commented on that this is potentially virus typical kind of ground glass appearance here, and we should further clarify. So this is one other aspect that we will be seeing also in cardiac CTs, findings that are indeterminate or maybe coincidental, that might need clarification. The patient had no symptoms whatsoever, no clinical suspicion. Of course, we had, after this CT finding, to do a swab that was negative, actually 2 swabs. And then we did the coronary angiography because of his symptoms, which confirmed the lesion. You can see it here and there. So we're expecting also, as a coincidental findings in the CT that might lead to overdiagnosis of findings. So one limitation of CT in this context is the image quality. If the patients are quite sick or not ideal for the examination. And a second limitation, of course, which is related to any anatomical imaging modality, whether it's CT or maybe invasive angiography, is the issue of stenosis. Is it causing ischemia and revascularization? So this is 2 examples here of an RCA lesion. We know it's obstructive, so visually by looking at the lesion, it is obstructive, doesn't cause ischemia. It's a question that cannot be answered by looking at the stenosis. It needs further clarification whether non-invasive or invasively, and this is what we usually do in clinical routine. If we do a CT and it's negative, it's clean, or it has no significant disease, and we need no further workup, no angiography. If we have disease, ischemia testing prior to revascularization is usually, or depending on the anatomy, then we need non-invasive ischemia testing, whether MR, whether echo, maybe some time in the future with CT, and then the other way around is to do invasive clarification and FFR. So this is as far as the coronary examination CT is concerned. Beyond looking at the coronaries, how could CT be used in the context of the COVID patients? We've seen, or most of you have seen, the publications and the information about myocardial injury in the context of COVID-19 infections. This is one editorial that looked at a number of trials, most of them you can see coming from China, relatively big populations, all published within the last 2 months. And we've seen also a number of case reports reporting myocardial injury, myocarditis in COVID patients, typical chest CT findings, and we'll be seeing that in the next presentation, and ECG findings, as of course, finally the final diagnosis, apart from the biomarker elevation, the troponin elevation, the MR for the tissue characterization for the definite diagnosis of myocarditis. So how can CT help with that? And I am grateful, Gianluca Pontoni is one of the cardiovascular CT experts in Italy who have faced a lot of patients, especially in the Milan area where he comes from. He sent me this case report. It's not yet published. It's in Proof and JACC Imaging. One example how CT could be used as a substitute for cardiac MR within the context of myocardial injury. Patient had, I think, around 50 years old, had dyspnea and had chest pain and had some mild troponin elevation. They were, their management was first to do a CT in any patient suspicious of COVID because of the big amount of patients that would not allow them to wait for swabs. So the patient was sent for a CT chest that showed initial findings typical for viral or a COVID infection. And because of the chest pain and some mild changes in the ECG and the troponin rise, they used the CT to clarify the coronary anatomy, which was negative, so no stenosis. And they did, after the first CT, a so-called delayed enhancement, so a delayed acquisition after the first pass, 10 minutes after contrast injection, usually around 10 minutes. And you can see here with the blue arrows, this is a cross-section at the mid segment of the left ventricle. Here's the left ventricle, and you can see this enhancement, this contrast enhancement here, as well as in the sort of a posterolateral view here in the posterolateral wall, what we call epicardial late enhancement, specific or typical for non-ischemic myocardial injury. So this is clearly not caused by a coronary problem, because myocardial or ischemic late enhancement go from endocardium to the epicardium, the other way around, and epicardial enhancement are specific for non-ischemic etiologies. So the use of CT, the patients are already in the CT scanner, and for the logistics, it's simpler. The exam is shorter compared to the MR. The patients do not have to hold their breath for a long time. So logistically, especially that they already have a CT scanner dedicated for the COVID patients, is easier. And this is how it's done. So this is one patient from our department here. It's not a COVID patient, but just for those of you who are not very oriented with this, with the delayed enhancement in CT, it's not very common. We do the first pass coronary angiography, which is a normal coronary CT angiography with the usual contrast injection. You can see the coronaries here. This was a patient, a young patient with chest pain, clearly normal coronaries. And after the first injection, we wait for 10 minutes and repeat a second scan, so 10 minutes, and then we do a delayed phase to look at late enhancement in the myocardium. If there is myocardial injury, then the contrast would go in and would not be washed out. So this is the concept of late enhancement. The myocardial injury, the injury of the cells, cause the contrast to move into the myocardium and is not washed out. You can see here, this is a sort of a 4-chamber view in the CT after 10 minutes, and you can see typical epicardial enhancement, this white enhancement here after 10 minutes, and this is the correlation with MR, which is quite nice. The image quality is not as nice, but it is doable in CT. So it's easier because it's a shorter procedure. Patients potentially in the COVID situation are already referred for a CT chest for clarification of the lungs, maybe for pulmonary embolism like this patient. But of course, the limitation is the signal to noise, and you need some expertise. Now, the other aspect beyond using CT for looking at myocardial injury, which is potentially possible, especially if there's no MR equipment or no MR expertise, is using CT as an imaging modality to substitute for transesophageal echocardiography. Now, this is a nice image here from the Canadian Journal of Anesthesiology. It's not for a patient who's having a TEE. It's an experiment looking at the potential droplet infection in patients who have extubation with and without drapes. So this is without drapes. There's a mannequin here, and using an air gun, they simulated sort of coughing. So any aerosol generating procedure, and everything that is white here is contaminant. So there's some debates whether TE is an aerosol generating procedure, but it is clear the close distance to the patient potentially would cough and cause droplet infection. So we deal with them, the TEs, in those times as potentially infectious procedure, and we actually cut down on the number of TEs in the early time. Indication have to be extremely solid, and the TE would have to really answer the question that would have a significant impact on the clinical decision making. So maybe CT can be used as a substitute for TE in different clinical situations. One possible situation, not sure how often that would be in a COVID patient, but it would potentially be an indication, is to look at the left atrial appendage prior to cardioversion instead of doing CT. You have less personnel exposure As said, sometimes the patients are already in the CT lab, and usually we can very nicely see the left atrial appendage within the first pass, so after the first injection. And if we need to if we really need to look at the left atrial appendage in atrial fibrillation, then we need to repeat the scan, a so-called delayed phase. So this is a common finding in atrial fibrillation. It looks like a thrombus, but if you repeat the scan, it's no thrombus. So it's just poor mixing of the contrast. Another example here for a real thrombus of the left atrial appendage, and you can see it here in the delayed phase as well, which is 20 to 30 seconds after the injection. And studies looking at the sensitivity of CT to exclude thrombus, if they do a delayed phase, have a very high negative predictive value. And the second thing for the substituting the TEE is for valvular assessment. Because of the volumetric data, maybe in the context of endocarditis, you can see here the one patient with the bioprosthesis of the aortic valve with an LVOT abscess here. So this is the cavity of the abscess. This information can be nicely delivered by CT. So going to the last slides, I asked some opinions from around the world from friends having big cardiac CT centers from different parts of the world, and they all had some different management strategies. For London, for example, one in the University of London, they did cut down the elective cardiac CT for non-urgent causes. If they have atypical chest pain, all of that was suspended. The CT was done routinely then for hospitalized patients or the symptoms suggestive of high-risk anatomy, left main or multivessel disease, or when CT was felt to practically replace MR and nuclear. And generally they had less numbers, but now they were starting to ramp up. This was London. In Canada, they had generally modest burden of COVID and no use of cardiac CT in COVID patients, and rather lots of chest CTs. In Vancouver, in Milan, a very big center in an area hardly hit by COVID, no non-urgent clinical activity whatsoever, extensive use of chest CT for pneumonia and pulmonary embolism, and they divided the hospital into a clean and a dirty part using the CT. And recently they're doing more cardiac CTs like the one I showed you for ruling out acute coronary syndromes or to substitute for MR for issues of myocardial injury. And last but not least, in Brazil, they're having lots of numbers, a big population, more or less similar to ours, tons of chest CTs. They avoided any cardiac CT in suspected or confirmed COVID for personnel exposure. Some cardiac CT in suspicion of acute coronary syndromes with troponin to avoid cath, because in this context, maybe it's even more work and more PPE in the context of the cath lab, and more for MR for the issue of myocarditis. And recently the SCCT, the Society of Cardiovascular CT, had a statement or a guidance for the use of CT. I will not go into details, but it can be easily downloaded and read. It's about how to use CT in a sensible way and to avoid doing any examinations that are not urgent. And with that, I would like to conclude. So cardiac CT in the era of COVID-19, I think it's a very good option to rule out and avoid admission of patients, rapid clarification of symptoms and to calm the patients down, exclude left main disease, especially now after the Ischemia Triad results, only studies that have sensible consequences and relevant consequences. Image quality is very important. Personnel and patient safety are crucial, and potentially substitute other imaging modalities if there is risk of aerosol or droplet generation. Thank you very much.
Thank you very much, Dr. Marwan, for this elegant presentation. As you mentioned, the situation everywhere in the world, let me tell you about the situation here in Egypt. We have the same, exactly like you mentioned, we have in the last 2 months very limited numbers. The referral is very limited. I think I would like to thank the professor that they do a better job not sending those elective patients or patients they can wait. Nowadays, we start again to see more patients, but let me tell you, in the last 2 months, we have like 5–10% of the usual numbers we have in the similar months each year. Taking the opportunity of moderating your session, Dr. Marwan, let me ask you first the question that usually there is a debate about the incidental findings during interpretation of cardiac CT, that are we responsible to write down or to comment on those incidental findings or not. I think it's a must now during this pandemic. If we doing cardiac CT for a patient with symptoms of chest pain, which is known as another, which the chest pain itself is known as a symptom of COVID infection. Sometimes those patients, they presented with chest pain. Are we responsible to comment on any finding of the CT chest? Or it's a must to include a radiologist with us to conclude the study so he can comment about any affection rather than the coronaries?
I think that, as you mentioned, it was a debate, but in the current times, having the lungs or part of the lungs being demonstrated, at least is my opinion, I completely agree with you. It's a must to have a radiologist to have a look on that for any potential coincidental findings that might have consequences for the patient, for his family, or whatever the population around him. We have the pleasure to have a radiologist who always looks at the lungs in our patients. We started maybe 15 years ago by having to look at the lungs ourselves, and if we see any pulmonary nodules, any changes, we call the radiologist. But now every single CT scan, the lung fields are checked by the radiologist. And as said, one potential example, maybe it's overcalling, maybe you will have more work, but I think within the times of this pandemic, having a look at the lungs is essential.
Okay. We start to receive some questions from the our colleagues and attendees, but let me choose the relevant ones, because there's some irrelevant questions. I gonna read some of them if you like to answer it. How frequent is CT of the heart used in pediatric patients? I don't think.
I personally don't do pediatric CT, so it's just a feeling. It's done by our colleagues from the radiologist, and it is not very infrequent, but especially in the last times it was not. Usually those patients are critical, so if they need the CT, it would be done, but it's not that frequent.
Okay, I think this question is very relevant to Dr. Marwan. You elegantly present one very important slide. I see for the first time the usual tests we used and the probability of the tests and how we can rule in and rule out. This very, very nice slide actually. And there is a relevant question from Hagar. This means, the question said, this means we can use coronary CT in high pretest probability for ischemia in COVID-19 era instead of invasive procedure, please.
Yeah, probably it is. It is not a bad idea, at least to exclude left main and proximal LED disease. We've seen the results in this ischemia trial. A patient profile. So patient is not in heart failure, patient does not have a severe LV function. I think the information of not having a left main disease or proximal LE disease is enough, at least to know that optimal medical treatment is not a bad option, unless the patient is really suffering from frequent angina, which is a totally different issue. So it does work well, even in high risk or the higher likelihoods, to rule in or rule out. And we know now, or we have the data, if we exclude left main and proximal LAD disease, your outcome on medical treatment is not that bad.
Okay.
Dr. Marwan, I would like to ask you a question first. Let me tell you how marvelous was the lecture is. I really was concentrating 100%. All the slides were very important, and thank you very much for sharing with us this up-to-date information from Germany, from an expert in CT. Let me ask my question about how frequent you are using CT as for the quadruple rule-out diagnosis. I know this is one of the advantages of CT, that you can rule out many diseases at the same setting. So how frequent you are in need?
quadruple, now adding the COVID also to the
Yes, exactly.
to the pulmonary embolism, dissection, and the coronary artery disease.
Exactly.
Well, there are two aspects. So our use of cardiac CT to exclude acute coronary syndromes increased in the time of the COVID from the emergency room, but we generally do not or did not perform much of triple rule outs, and now it's quadruple because the protocol is a little bit different. So if you really want a comprehensive CT, then you need to cover the entire lung, so a complete CT chest with or without contrast. And for the pulmonary tree, you need a different timing of the contrast protocol. So we were not, even before COVID times, not very much fans of using the triple rule out aortic dissection, pulmonary embolism, and acute coronary syndromes because you do not get the best image quality for the coronaries, which is important, especially if we need to comment on plaques, on details of the coronaries. Our use increased for the acute coronary syndrome for discharging. We wanted to have the opportunity to send patients back home, but not really within the context of a quadruple rule out.
How did I have one more question, and
okay, go ahead.
And then Professor Amr, if you want to
yes, I would like to ask you thank you for this elegant talk, and I'm very happy that to see the Egyptian in Germany, they're doing everything excellent. So I would like to ask you, do you think that the use of cardiac CT, I think now in Germany is increasing because there is a lot of cases you can discover during the CT, cardiac CT, that is the chest pain is maybe from COVID. You need to mention in your reports, I think, it's probability of
الصوت راح شوية بس كمل بس.
الصوت راح شوية بس.
لا الصوت راح يا دكتور عمرو. انت بتعمل ميوت ساعات او
لا. You hear me? Okay.
No.
You hear me now?
دلوقتي كويس.
You can repeat it. You can repeat the question, Dr. Amr, shortly.
I mean, if you find any signs of COVID-19 during your cardiac CT, you need to write in your report for the cardiologist, because a lot of patients come with chest pain, and always you are thinking that maybe coronary artery disease, but the problem is not. So this will reduce the risk maybe for the cath lab team, and maybe if you see any for stratification even of your case, and you can write just that he may send the patient to a pulmonologist or something like that.
Yes, indeed. We have to, I think we have to report the lung part, but again, the cardiac CT is usually not a comprehensive scan of the entire CT chest. So one part we have to report. But on the other hand, we probably will see lots of post-inflammatory lesions, and maybe our Dr. Ahmed later on will comment on that are not COVID related. But then, because of the situation, then we were overcalling post-inflammatory lung lesions as COVID as well. And the patient who is rather with typical symptoms, clear ECG changes, we did have a dedicated cath lab for COVID. Or COVID suspects. So those patients, I think it's even better to go directly for the cath lab. So the higher the risk, otherwise you have them in CT and in the cath lab.
Dr. Marwan, you mentioned that the Ischemia trial has changed the guidelines and has upgraded the CT scan compared to maybe sometimes the physiological tests like the SPECT or the exercise test and with imaging. Did this had an impact on our answer? I mean, the number of patients doing CT became more to exclude left main and to exclude coronary artery disease, and then perhaps medical treatment in other cases, or still you are the same practice is not has not been changed?
We're more or less the same practice. Probably because we're a high volume center and a referral center, so we did not really have any changes. The Ischemia trial have only been published recently, but what really changed the guidelines as far as CT is concerned was the Scott-Hart trial. But the Ischemia trial, I think, will change the perspective of some interventionists, and maybe at least the conservative ones from them, that optimal medical treatment for some patients is not a bad option. It's not typical to let the patients have angina every other day, but for some of the patients, especially to avoid admissions, especially in the current times, probably it's not a bad option.
Dr. Islam?
Dr. Sameh, if you feel that we exceed the time, just let me know. We have some couple of questions, Dr. Marwan, from our colleagues. One of them, when would you advise stress echo rather than CT for ischemia, risk stratification in current era, in intermediate pretest probability?
I am, of course, very biased to CT. The answer
I think the answer is clear in your presentation. According to the expertise, if you have a good expertise in echo, so go with echo. You know.
The answer, I do stress echoes myself, but the answer in CT is much direct. If you don't have good image quality, and if you have resting region and wall motion abnormalities, then the documenting or reporting a stress echo might be very difficult. And the answer for me, for the CT and the potential consequences, statins, how much plaque and so are much clearer. So if here in Erlangen, we don't do that much stress echoes. Yet rather, if we have stent patients, bypass patients, rather MR or nuclear.
There's another question from Mohamad Hatim. Should we make CT in young with COVID-19? I don't understand that he mean CT coronary or chest CT. So anyway, should we make CT in a young with COVID-19? I think the answer is yes.
If the suspicion is of a coronary assessment, then it's yes. But nowadays, even in a young patient, the radiation dose is very low, so it's no problem.
There's one last question, Dr. Marwan. In COVID-19 patients, respiratory signs, especially tachycardia, may affect image quality. Setting for CT coronary as alternative to invasive procedure. To how extent?
It's a very good question. To the extent of what kind of equipment you have. A very good equipment and a not very tachycardic patient, probably it will work. The patient I showed actually was done on this CT scanner we have, which is not the best, 128 slice, which is still good, but the image quality was not optimal. Tachycardic, as she said, tachypneic. So unless the question from CT is very critical, it will change the management. I would rather wait till the patients are stable and then do the cardiac CT at some point when they're stable. And to what extent, it depends on the equipment and the expertise. If the old equipment, not much expertise, it's rather better to wait or just send them to the cath, which is never a bad option, if the question or the clinical indication is solid.
Okay, there is too many comments from Dr. Marwan thanking you for this elegant presentation and this very informative lecture. And by this, I would like to conclude your lecture, thanking you very much for this presentation. Thank you to be with us in this nice evening. Thank you, Dr. Sameh, for this opportunity of having Marwan with us tonight. And thank you for the company, Marcyrl, for the opportunity of having this cooperation with the Egyptian Society of Cardiology. Thank you very much.
But it will be kind of you if you continue with us, because we have a very...
Me, myself, I am.
And Marwan.
I'm there.
Okay, Professor Amr El Hadidy, would you kindly please introduce our next speaker?
Thank you, Dr. Sameh. First of all, I would like to congratulate Egyptian Society of Cardiology and Dr. Sameh Shaheen for this great effort that was done to have this position statement to 2020 for the management of cardiac patients in COVID-19 pandemic. Also, I'd like to thank all the board of the Egyptian Society of Cardiology, and I'd like to thank Dr. Marwan for his lecture, and I'd like now to introduce Dr. Ahmed Osman, the Professor of Radiology in Ain Shams University, and I think nowadays the lung CT is the main issue now in our country and all over the world, and I think the most now working in this scenario is the radiologist and the pulmonologist, and a lot of things to do and a lot of CTs. I think there is a lot of exhaustion of all CT in the world, not only in Egypt. Dr. Ahmed.
First of all, thanks a lot for Dr. Sameh Shaheen for his kind invitation. It's my first time with you, Egyptian Society of Art. Thanks a lot, Professor Amr El Hadidy and Professor Islam Shawky for this kind introduction. Thanks a lot, Professor Mohamad Marwan, for these informative and nice presentations. We'll talk today about coronary virus epidemic, and the radiologists have the rapid diagnostic clue. We will talk about our experience in Ain Shams University, either the General Hospital, the Demirtash Hospital, or in Ain Shams University Specialized Hospital. We'll talk about chest X-ray and COVID-19 infection as a baseline study for every or any pneumonic lung disease. Why we are starting to use the CT and why it began to be a cornerstone in diagnosis of COVID-19 infection. What we look for in CT film or CT study to diagnose the COVID-19 infection and to establish our probability whether this is high, intermediate, or low. Is the CT sensitive or not, and what is the differential diagnosis? As Dr. Mohamad Marwan said in his presentation, there is a lot of other diseases can make a feature similar to COVID-19. All the clinician must know how the language used by us in reporting COVID-19 infection to know to what extent the patient is highly suspicious. Follow-up dilemma when to follow up the patients either during the disease itself or even after complete resolving of the disease. And shortly we will talk about the extrapulmonary manifestations. Very rapidly, all of us know about a lot of information now about the COVID-19 infection, but I need to stress on specific information which is very important later on. COVID-19 infection is one of the coronavirus family. All of us know SARS infection, which also appeared on China 23, and MERS, which appeared in Saudi Arabia 2012. A lot of symptoms, non-specific, and even a lot of patients, different symptoms appears on patients' headache, sore throat, cough, dyspnea, shortness, chest pain. Even with the peaks now in Egypt, we see patients with GIT symptoms only, even neurological symptoms, loss of taste, loss of smell, even stroke. Chest X-ray is, of course, is a baseline study for any pulmonary symptoms, and it's characterized by being very cheap, available even in away hospital or low economic areas in Egypt. Yet, unfortunately, its sensitivity is a little bit lower than CT. It's only positive in 54% of non-severe form and 76% in the severe form. A lot of cases may express normal chest X-ray. And regarding the positive finding seen in chest X-ray in COVID-19 infection, COVID-19 infection characterized by a specific pattern in CT or X-ray, which is an opacity. Air in the lung appear as a black or opacity, and inflammation appear as white areas. Distribution is very important to characterize COVID-19 infection, being bilateral and peripheral. It usually spare the central pericardiac areas, even if it's extensive or extend from the periphery. As we see here, there is a peripheral opacities affecting the periphery of both lungs. Being atypical, it must be peripheral or predominantly peripheral or and bilateral. These more severe forms also involving the periphery and extending to the central parts, yet still the pericardiac lesions are sparing, and no pleural effusions. More and more severe, almost involving both lungs, yet still the pericardiac lesions are spared, both castopharynx angles are free, there are no pleural effusions. Being in pandemic, we will put COVID-19 infection as a first possibility. Why now we are using or overusing even the CT and become a cornerstone in diagnosis of COVID-19 in a lot of charts and diagnostic flows in a lot of societies. A lot of papers since February talk about the relation between the CT and its high sensitivity in comparison to the PCR. Radiology is one of the important radiology journals overall in the world. Discuss the sensitivity of CT may reach up to 97% compared to the PCR, which in this study, for example, detect 75%. And the explanation of the low sensitivity of PCR compared to CT, we need a time about 5 days to turn from negative to positive PCR, while during this period, the CT manifestations start to appear if we scan the patient by CT. Another paper also from China, as most of the papers now are Chinese edition, also in February, sensitivity almost similar, 98% compared to the PCR sensitivity, 71%, and explain the low sensitivity of PCR due to the technical difference between the PCR kits available all over the world. There is different types of kits which may be of different power to detect the PCR. The low viral load, and this depends on time of presentation of the patients. As we know, the COVID-19 start to replicate inside the nasopharynx and oropharynx, then migrate to the lung. So late presentation of the patient may cause low viral load on the nasopharynx and oropharynx, and this decreases the PCR sensitivity. Also, the technical issue. During swabbing may affect the sensitivity of PCR. One of the important papers talk about the PCR sensitivity decline according to the onset of presentations and the time of swab after the onset of symptoms, starting from 67 during the first week and decline up to 45% only during if the patient presented at the third week. One of the largest study about 1,014 patients and compared between the CT and PCR, and the sensitivity also similar, 98% in positive COVID and 79% in non-COVID patients. So the CT add to the probability, clinical probability, and the typical CT finding, which is peripheral, bilateral changes we will discuss later. We must consider the patient is positive even if the negative PCR, because if typical CT finding, a lot of patients we already seen in our university turn positive even after 4th PCR negative results. CT is very important, of course, to detect the severity of the disease, how much it involves lungs, presence of complication, other diagnoses rather than COVID, or even underlying lung disease besides the COVID, because it will affect the management of the patients. With all these factors, we can outbreak the COVID-19 spread because we need, and this is announced by Dr. Mohamad Marwan, even in emergency room, we make a CT chest for the patient to clarify whether it go within the isolated areas in our hospital or not. We meet a lot of positive patients with no complaint at all, just coming with trauma, polytrauma, or another abdominal pain, and we discovered a typical pattern in their CT chests. and the swab turned positive when was taken. This is our chart used in Ain Shams University. In the first era of the disease, there was availability of the PCR, yet with increase the number and no time to wait for the PCR results, especially in the emergency room, we turn to the CT directly and differentiate the patients, as we will discuss, to high probability, intermediate, and low probability. How to diagnose the CT manifestation of COVID-19 patients? The most specific and most persistent feature in CT is the ground glass opacity, which is present in positive patients 100%, whatever the time of presentation and whatever the cause of the disease. All the time of the disease, if we also do a follow-up, ground glass opacity persists. It's the first appear and first and last disappear. Increase or decrease, yet it persists. So a ground glass opacity is one of the most important and fixed finding, must be seen in the CT. It must be bilateral and peripheral in distribution. Plus or minus other findings, such as crazy paving pattern, and this is pattern all the cardiologists know it well because it's present in pulmonary edema, and plus or minus consolidations, vascular dilatation, fibrosis, architectural distortion, even so, as we will see. There is a lot of studies discuss this issue in the previous presentation about the distribution and the characteristic feature on COVID-19 infection. For the clinicians who will deal even there is no rapid radiological consultation, the ground glassing is like a curtain, which an opacity, a white area, yet and still we have see the underlying lung details, bronchi and vessels, like a curtain. Okay, as we see, this is all positive patients. Whatever the opacity of the ground glass, it's faint ground glassing. It must be peripheral in position or predominantly peripheral in position, and must be bilateral affecting both lungs. This is a typical feature which is almost 99% positive. If we find, mostly the patient will be a COVID-19 positive. Maybe rounded, still peripheral and bilateral, maybe patchy and linear, still peripheral and bilateral, maybe confluent, affecting even the central, yet still the peripheral affection is more predominant than the central one. As we see, the central is almost sparing, still the distribution, as we mentioned, bilateral, peripheral distribution. There is another science, as we previously said, plus or minus, beside the ground glassing, is vascular dilatation sign. It's not in normal patients, normal population, it's not usual to see the vessel dilated as we migrate from the hilum. Yet you do the localized inflammation, we will see a vascular dilatation in the areas of ground glassing. And this is reflected to the underlying inflammation. Also, crazy paving, which is the secondary to inflammation of interstitial septum. As we see, there is an overlying septal thickening overlying the ground glassing area, making a crazy paving pattern, like a curtain, yet with lines inside it. Yet I'm still seeing the underlying lung parenchyma and vessels and bronchi. We can also see consolidations, which has a complete opacity, obscuring the underlying lung, with or without air bronchogram, depending on accumulation of the inflammatory materials inside the alveoli and keeping the bronchi. This is post-broncho sham sign, or even extend to involve and fill the bronchial tree, causing total segmental consolidation collapse, yet still preserving the same pattern at almost peripheral, predominantly peripheral in distribution in post-COVID-19 infection patients. As we see, a lot sheets of subsegmental consolidations affecting the periphery of the lung, plus the fixed ground glass appearance. Another and last sign we can see in post-COVID-19 infection patients is what's called curvilinear lines. Some authors said it is an inflammatory fibrosis, which is resolving with time, and some said it's a matter of inflammatory consolidation yet taking a specific shape for COVID-19 infection, which appear as a linear opacity in parallel to the costal surface of the chest. There is important finding which is almost negative in patients with COVID-19. When we see it, the COVID-19 infection become of low probability. Massive pleural effusion, except if the patient developed secondary bacterial infection on top of COVID-19 infection. The nodular pattern, nodules, presence of nodules, especially if they giving what's called tree bud appearance, like the nodules appears in trees. This is more common to be within fungal infection or other viral infection. Presence of cavity, as we see, is more common to be bacterial abscess or fungal cavity lesion rather than COVID-19 infection. So presence of massive pleural effusion or nodular pattern or cavitary lesions, mostly excluding COVID-19 infection or make it very low probability. There is a lot of differential diagnosis for the COVID-19 pattern in CT, yet as Dr. Mohamad Marwan said, the relevance of the prevalence. We are in pandemic of COVID-19 infection. So in most of the cases, we will put COVID-19 infection our first possibility, not, for example, SARS or MRSA or cytomegalovirus, because we are almost in the peak. So we will always put the COVID-19 infection as our first possibility, especially if there is a typical pattern as we previously discussed. There is a lot of differential diagnosis without details. Infectious causes are just as pneumocytic pneumonia, yet in brief, most of the differential diagnoses show also ground glassing, resipaving, and consolidation, yet it's more central in position, and most of them show nodular pattern beside. As we said, nodular pattern is against COVID-19 infection, and the central distribution make us less probability for COVID-19 infection rather than the typical peripheral pattern. Cytomegalovirus, most of the time presented by nodular pattern, not the typical peripheral. Even if there is ground glassing, it will be more central. MERS and SARS are of the same family, so they will be atypical CT features like COVID-19, but we are in pandemic of COVID, not MERS or SARS. A lot of interstitial lung disease also give us the same picture as COVID-19 infection, yet the presentation is different, not acute. Most of the interstitial lung diseases are chronic diseases, and most of them presented with predominant nodular pattern as eosinophilic pneumonia. Non-specific interstitial pneumonia also give a crazy paving, maybe peripheral ground glassing, yet additionally we will see extensive fibrosis peripherally. COVID-19 may show some fibrosis during the resolving stage, yet not extensive as interstitial lung diseases. Usual interstitial pneumonia may present also a ground glassing, easy paving, yet extensive fibrosis and the characteristic uncomping cystic-like changes, very peripheral in position. All these make us to suggest interstitial lung disease rather than COVID-19 infection. Cryptogenic organizing pneumonia, one of the most important differential diagnoses for COVID-19 infection, because it's usually presented by the same manifestations, maybe fever, maybe body aches, maybe fatigue, maybe headache, dyspnea, shortness of breath, and almost have the same similar pattern as COVID-19 infection, bilateral, peripheral, crazy bathing, and consolidations. And this is one of the most important dilemma during, between radiologists to differentiate between cryptogenic organizing pneumonia and COVID-19 infection, which is always solved by the lab and clinical correlation, because it's a little bit different in his lab results. Respiratory bronchiolitis and desquamative interstitial pneumonia, all these are interstitial lung diseases also presented by crazy bathing, ground glassing, yet as we previously said, it's more central in position. So when we see CT for patients with suspected COVID, or even during in emergency room, yet the central ground glassing is more involving the central parts of the lung, the probability of being COVID-19 will be less. It will be intermediate probability, not typical, and this is usually completed by the lab and clinical picture of the patients. Pulmonary edema, also it is completely different from the typical distribution of COVID-19 infection, being it's involving the central of both lungs, as all the cardiologists, of course, familiar with the pulmonary edema features, being bilateral, symmetrical, central, ground glassing, even crazy bathing, the same pattern, consolidations. Yet we must alarm that COVID-19 infection may worsening the cardiac conditions in cardiac patients, so we may develop the pulmonary edema because of underlying COVID-19 infection. Even some papers told us about the late complication and most severe complication of COVID-19 infection may be in the form of ARDS, or acute respiratory distress syndrome, which is similar to pulmonary edema. In CT, of course. What about the reporting language used in CT COVID-19 infection reporting? There is a lot of schools, American School, American Congress of Radiology, British Thoracic Society of Thoracic Imaging, and CRAT system used in Netherlands and Europe. All of these are almost similar to each other. We are talking about the typical features. In Egypt or in our institute in Johnson University, mostly we use this flow chart or the guidelines of American Congress of Radiology, typical or high probability, which is previously said, it must be finding ground glass is the basic. It must be peripheral and bilateral and multiple. Being central, perihilar, for example, or unilateral involving one lung, ground glassing, it will be in detriment or intermediate probability. As we previously said, lobar consolidations, effusion, lung cavitation, nodules, all these are atypical or of low probability for COVID-19 infection. Unfortunately, we must take care of normal and negative CT because it may be normal in very, very early stage of COVID-19 infection. In brief, the typical and high probability CT finding for COVID-19 infection is highly up to, as I previously said, 90% is positive patients, even if PCR negative, because our experience from 2 months ago up till now, we do about 250 CT in our general hospital per day, CT chest, and in Johnson University Specialized Hospital, we do about 100 CT chest per day, a huge number. Mostly the typical finding and the high probability is till now almost 100% is typical. Intermediate probability is almost 50 to 70%. Low probability is about 30 or less percent. Negative is a matter of debate, not yet agreed decision how percent it will be positive patients. If we see a correct system in the reporting, it will be numerical, CORAD 1, 2, 3, 4, 5. It's not related to the severity, it's related to the probability. CORAD 1 is almost normal or present of any other non-infectious abnormality in the lung, mass, emphysema, or any else calcifications or whatever. And raising the number indicate it's more and more suspicious till CORAD 5, which is the typical, similar to the American society. So, lastly, diagnosis of COVID-19, it must be a triad of laboratory, CT, and clinical suspicious, especially in intermediate and low probability cases. Yet, from our experience, typical cases is still, even if no symptoms, even if normal lab, it's considered positive patients. How about follow-up of the patients? It's a matter of benefit and risk. Because of all of us know, it's still a radiation. CT is still, we have a risk of radiation. Also, we try to use a low dose CT technique to increase the radiation dose for the patients. Yet it's still a matter of debate. So we almost guided by the issue that we must know. CT changes over the time of the disease is changed with time. During the early 4 days, almost may be normal or ground glassing. During the first week, this is called the progressive stage, we can see increase in the ground glassing and appearance of crazy paving. During the second week, we may see the consolidation pattern. And after 2 weeks, there is improvement in the disease and the appearance of fibrous strips, which may last even up to 1 month and even after negative PCR of the patients. So, Fleischner Society for chest, for example, put 3 scenarios according to the symptoms of the patients and according to the resources availability and depending on the risk factors for the disease progression, which is old patients more than 65, diabetic and hypertensive, cardiac patients and immunocompromised patients. If the resources are available and mild symptoms, we do a baseline study CT for the risky patients, only risky patients who do baseline study, and during follow-up, we limited the use of imaging, whatever chest X-ray or CT, if there is worsening of the respiratory state. Only in this case, we do a chest X-ray or even CT for the patient during the disease period. Scenario number 2 is about moderate to severe features, and still there is availability or resources availability because being moderate to severe, he put Fleischner Society put the imaging as a baseline study, then also limit the use of follow-up CT or X-ray only if there is worsening of the respiratory states. Scenario number 3 and last scenario is depending on just like what we facing now in Egypt, peak numbers of patients with a little bit shortage in resources, especially in PCR. So he depend either on rapid or even in the imaging for categorize the patients and also still limiting the diagnostic radiological imaging during follow-up only if there is worsening of the respiratory status of the patients. British Thoracic Society talk about the follow-up after improving of the symptoms and after discharge of the patient, either from the CCU, ICU, or from the ward to be using chest X-ray only after 12 weeks, which is something weird about pneumonias. We always follow up pneumonias after 6 to 8 weeks because we are fearing about any underlying mass lesion, for example, with pneumonias or bacterial pneumonias. Like yet in this viral pneumonia, Just we want to see if there is any residual morbidities or some patient developed chronic pulmonary embolism. About the extra pulmonary manifestation of COVID-19. Cardiac, and our colleague, Professor Mohamad Marwan, expressed the situation about cardiac issue during COVID-19 pandemic. There is a strong theory about thromboembolic effect of the COVID-19 infection with development of pulmonary thrombosis. Yet, in our institute, we faced only one case during this, the previous 2 months or even more, because we think it's the thromboembolic started mainly on the level of the microthrombi, microvasculature, which is beyond the ability of CT. So to develop such major or central thromboembolic manifestation, mostly this is a late disease process. By the same theory of thromboembolic effect of COVID-19 infection, we see patients with renal infarct secondary to renal thrombosis. And one of the measures with increase the number of the patients is the neurological effect of COVID-19 infection. There is a lot of theories about the neurological effect of COVID-19 depending on presence of RNA particles of the virus inside the bloodstream and attacking the angiotensin converting enzymes receptors 2, which is present in the brain, or secondary to hypoxic brain damage, or cytokine storm, or even the thromboembolic theory, which was a lot of papers talk about acute hemorrhagic necrotizing encephalopathy involving the post-lamine bilaterally, form of inflammations and areas of hemorrhage, even may involve post-temporal loops, and all of these presented by neurological manifestations as even convulsions, deliriums, loss of consciousness. This pattern, when we see in this pandemic, we must do CT chest because it might be a complication of COVID-19 infection. Also, stroke in young patients. It's not acceptable for young patients to experience a stroke. Yet, so in this pandemic, stroke in young patients, even CT conventional angiography revealed complete occlusion of the basilar artery, for example, stroke on the right side of the brain. In young patients, we must expect COVID-19 infection. Lastly, Wuhan is the source of infection, yet by the world, it's maybe our protection. Wash your hand, use mask, have temperature regularly checked, avoid large crowding, and never touch your face. As Dr. Mohamad Marwan said, also we are in pandemic and we are very exhausted by a lot of CT, yet don't hesitate to contact the radiologist because we may have solutions regarding the COVID-19 infection. Thank you. The variable of patients, already positive patients, this is a life as we interpret it. We see the lung windows. As we see, there is a peripheral ground glassing here, faint peripheral ground glassing. Yet, as we said in the they are multiple peripheral in positions and bilateral, involving both lungs. And even we see there is a positive vascular dilatation here, and so it's almost a caliber here increasing in comparison to the adjacent lung parenchyma, normal lung parenchyma. This is secondary to, of course, the inflammations. This is a nice case of COVID-19 infection. This is more severe form. We have a peripheral bilateral consolidated patches with ground glassing. And lastly, a very nice case for follow-up. This is a patient done 3 follow-ups. And this is supports the idea of please confine the follow-up only if there is deterioration of the respiratory symptoms, because this patient, for example, just phobic from COVID-19 infection. He's a colleague, doctor colleague, medical colleague, so he's panic from COVID-19 infection. He do a lot of CTs, 3 CTs. Also, he was fine with no any progression of symptoms. In controversy, he was regressive in course. And I told him you will take a cancer from radiation exposure, and your COVID will be treated, inshallah. Also, the regression of symptoms, yet, as we see, we started by faint, very faint, peripheral bilateral ground glass patch, as we see here, and then it be more opaque, more ugly in CT. Lastly, after 3 weeks, it's more ugly with development of consolidation patch and fibrotic bands, as we see here. Also, he is clinically good. So, limit the follow-up for the clinically deteriorated patients. Thank you.
Thank you, Dr. Ahmed, for these live presentations for these lung CTs. I'd like to ask you just a very annoying for me, the scoring system for this lung disease, because we know the typical findings, as you mentioned, multifocal ground glass opacities, peripheral and basal distribution, unsharp of the demarcation, the vascular thickening, as you mentioned, around the crazy paving, the ground glass and consolidation, reversed halo, and the spider web. Do you think this is the usual typical findings, yes, of these COVID-19 patients? And we are somehow disturbed in scoring, because which patients you need to score him that this patient is a mild or moderate or severe, even the severest case, which you mean the use of the peripheral, the basal, I know that the lobe is not so lobar affection is not with COVID-19, but which the central or peri-bronchovascular markings this will add the apical distribution. I don't think it's atypical, but I need to tell me if you look to the CT, this is a mild, this is a moderate, this is a severe, or you have a scoring system. If you have a scoring system, peripheral, central, basal. This is one question. Okay.
Regarding the distribution, it's not. Usually, a lot of papers talk about the posterior and lower lobar distribution, which is not mandatory. Okay. Regarding the severity, score developed in Europe nowadays, almost similar, and the score used since SARS attack. This is the most used. This score depends on the distribution and degree of involvement of the lung, not on distribution, degree of involvement. If we divide each lung into 3 zones, carina, above the carina, between the carina and inferior pulmonary vein, and from the inferior pulmonary vein to the diaphragm, we have 6 zones. Okay, if the percent of involvement, whatever by ground glassing or consolidations, if less than 25%, it will get score 1 for each zone. And if 25 to 50%, we get score 2. And we collect all the scores. Total score will be the highest score for each zone is 4. Total score will be 6 multiplied by 4 is 24. Yet there is still a debate about the correlation between the severity and the score. There is a lot of papers correlate between the severity score and the presentation. Yet another papers still documented, and we see in our experience, as I said, we have a lot of CTs in Ain Shams University General Hospital and Specialized Hospital. We see non-symptomatic patients at all, and they have a severe form of COVID-19 and they positive patients. A little information about the prediction, whether it's okay. Still a debate about the clinical manifestation and severity. What about the prediction? If the patient is presented with us by severe form, can I predict it will be deteriorated rapidly or not? Is still a debate. But the most solid information up to now about the risk group, severe form and risk group, mostly they deteriorate, and the extensive consolidation pattern, mostly they will deteriorate.
Okay, so if you have just a pleural pleuropulmonary reaction, just for in the follow-up, do you think this patient need more CT? If you have a pleural reaction?
Once it's clinically stable, no CT is needed.
So you mean that if you don't need to repeat the CT unless there is clinical...
This is the last example. This is the last example of our colleague, phobic colleague. It was completely symptomatic in the last.
In spite of the CT change.
He started to be less panic from COVID and more panic from the CT pattern. Because it's become more ugly.
Okay.
Dr. Amr, I had a short question. Thank you, Dr. Ahmed, for this excellent presentation. As we mentioned, as Dr. Marwan mentioned in his talk, that when he have a consensus with his colleagues about the rate of the cases, let me tell you that there is a saying which is said, some people's disasters are others' benefits. مصائب قوم عند قوم فوائد. And this is actually works very well for radiologists, radiology centers, and the radiology colleagues. We have too many cases right now. So, but let us look at it from the other direction, because I used to ask my colleagues, the technicians, about the number of the cases here in Egypt, and it gives me the pattern of the cases. And they said to me that the last weekend and the beginning of this week, which this is the highest number of the cases in each radiology center. They have almost 200 cases. 50% of them, they are COVID-19. And last yesterday and today, they said that the number is a little bit lower and the number of positive cases is less. This is a case which may give us a reflection that the curve is going down or not.
Almost this is right. After Eid al-Fitr, we suddenly, even the number of cases which presented by symptoms of COVID-19 infection horribly increased. As we said, we facing up to 250 per day in Mardash and 100 or 100 and more for a specialized hospital, Ain Shams University Specialized Hospital. And almost more than private, we almost get by randomized sample, we get 60, even 70% of the cases positive patients. And this is last for really the last 2 days. Still the percent not little lower, 50, 60, but the number who presented is less.
Okay.
The number in the last 2 days in the Mardash and Ain Shams Specialized Hospital is less than.
It's exactly the same everywhere. Yeah. Thank you, Dr. Ahmed. Thank you very much. And I want to congratulate Ain Shams actually. If we give the gold medal for the best practice in the COVID affection in Egypt, I think it goes to Ain Shams University. Indeed. Of
course, it was a challenging. We get the benefit of our machines at maximum. We have in the Mardash 5 CT machines. And
you have Dr. Ayman Saleh too.
Oh, yes. And our header, Dr. Ahmed Munib, from the day one, we get the benefit of having 5 CT in the Mardash Hospital. So we have the opportunity to isolate 1 or even now 2 machines for suspected COVID patients and 3 machines for the mainstream medical health service. We try to balance between the COVID fight and the mainstream health service. Also in Ain Shams University Specialized Hospital, we have 2 CT machines. One is for suspected COVID-19 patients, and the other is for the main health service for the other patients. And this was the idea.
والعبور بتعملوا فيها ايه يا دكتور احمد؟
العبور is completely there is one CT machines, but all the patients are positive, so no need for.
That's for follow-up, yeah.
They almost follow the same protocol. They don't follow up if there is clinical deterioration.
Okay. So, Dr. Ahmed, do you think that the presence of pleural effusion is maybe against, or do you think this is maybe secondary infection, maybe something extra than viral than COVID-19?
Presence of massive pleural effusion is against COVID. Yet, mild pleural effusion, especially in cardiac patients, he is not protected against COVID. Why not? It's especially COVID-19 may worsen the cardiac.
Or renal patients, Dr.
Or renal patients, of course. We have about a lot of cases presented by acute kidney injury and ascites effusion, and we discovered it's a COVID-19 positive because it attacks the kidney. Even there is recent papers talk about the radiological phenotype of COVID-19, and they discovered that, of course, although we talk about the local pneumonia and effusion are of low probability, yet this is the most feature found in ICU patients.
Do you think the massive lung infiltration in the CT, when you have cases in follow-up, and these patients still have persistent hypoxia, and this patient shows it does not improve, and they need all the time oxygen. So these patients, do you see some patients with lung fibrosis?
Still not yet.
Still not yet, even in the follow-up.
Just the fibrotic bands, the arcade pattern, and
but not massive fibrotic.
No, not yet, not yet. Still, we have not yet follow up the patients. We are still in the peak. So, I think this will appear later on. As I share a slide of British Thoracic, they recommend 12 weeks follow up after the resolving of the symptoms, because the usual changes, some papers, and we see this the finding persist after even up to 1 month, and then resolve it. So this is, I think, the same result of British Thoracic Society, who recommend follow up after 12 weeks. To be sure that all the features which is reversible will disappear, and only the residual will be the morbidity. Or
even you have no symptoms, huh?
Even you have no symptoms, of course.
You need follow up even you have no symptoms after 12.
Yes. British, any pneumonia, it's a patient, and I told this in my presentation. Any pneumonia must be followed up. It's a bacterial pneumonia, especially in old age. Usually,
even it's mild.
Yes, because we fear of underlying. It's not practical in healthy patients, mainly to develop pneumonic consolidation in lung without, especially if persist and resistant to the treatment. So it must be followed after resolving, because there is a lot of cases we discover underlying disease. Yet in COVID-19, it's just a virus. And this is the sequelae we see in all patients. So they belong the period of follow-up after remission to 12 weeks. I think in Egypt, we will not wait for 12 weeks. It will be more aerial than that.
Okay. So
there are some questions, Dr. Amr, in the question.
I will read it, but some of them are usually irrelevant. But we have one question. Unilateral ground glass without auscultatory findings. Sometimes this is a question.
if unilaterally changes, it will be indeterminate or intermediate probability. 70% may be COVID, maybe other viral infection.
Okay. Another question: how it's possible to differentiate between ground glass appearance in hyaline membrane disease in preterm and those infected with COVID-19?
The pediatric patients is a matter of dilemma because we have little experience in pediatric age group, yet the little number we have positive patients in our hospital, unfortunately, most of them presented by atypical features at all. Nodular consolidation, loopar consolidation, loopar pneumonic, which is all are low probability. They develop positive COVID. We discovered they positive COVID-19. I think the dealing with the pediatric age group must be different because they are not follow the typical features of adults.
Okay. Any questions, Dr. Islam? Sameh?
Dr. Marwan, is there any comment?
Maybe one clinical comment. I can just confirm what was mentioned by Dr. Ahmed very nicely, that a negative swab in a typical CT with a typical clinical scenario does not exclude COVID, because we've seen that in clinical routine quite often. In patients, number of negative swabs, typical CT, deteriorating up to intubation, and after intubation, tracheal bronchoalveolar lavage was positive after 4 negative swabs. So a typical CT with a typical clinical constellation, and especially with contact, is more decisive than a negative swab. And this is the only comment.
I think they also upgrade the protocol here in Egypt, Dr. Ahmed, based on the CT finding, that they include only patients with CT findings rather than having swab or not, or positive lab or not.
As I said, typical CT finding in the middle of my presentation, typical CT finding, it must be considered positive patients. We have, as Dr. Marwan said, we have an experience in Ain Shams University Specialized Hospital for one of our colleagues. We have 5 PCR.
Dr. Ahmed, the Minister of Higher Education said that we're going to have 40,000 affection. I think we approached this number today. So that's it. I can go to work Saturday or not yet? Do you remember the joke that someone come with a very severe illness to a surgeon, and he said, the patient said to the surgeon that, I know that my operation is very hard, and, the 90% of patients die. So the surgeon said, I know, but you will be succeed. He said, why? The surgeon answered that the 9 patients before you already died. So you are going to be the 10%. So they said 40,000, have affection. So I think we approach this number now. So
I think the number is more than this number, 40,000, I think.
نسأل الله أن يرفع الغمة يا رب إن شاء الله.
The main issue is with the highest number of patients, we face a lot of atypical forms because there is a lot of patients. So we more and more see a lot of typical forms, and this is a matter of dilemma. It's
we have another joke.
COVID-19.
we have another joke now that we have 20,000 recovered patients from COVID, and we have 300,000 patients want to donate with their plasma. So it's
each one gives a more.
Dr. Sameh there, or
yes, this lovely atmosphere. سامعني يا شباب؟ سامعني يا دكتور اسلام؟
Yes. دكتور عمرو I don't forget.
سامعني؟ أنا موجود معاكم.
دكتور سامح سامعينك، اتفضل.
يعني ما فيش اجمل من كده بقى ننهي السيشن الجميله دي عشان وقتكم، طبعا وقت حضراتكم. بنشكركم، بنشكر استاذ الدكتور اسماعيل الجميل اللي اضافوا على والمناقشات الممتعه اللي اضافوا على هذه الجلسه. بنشكر استاذ الدكتور عمرو الحديدي. بنشكر اخويا العزيز استاذ الدكتور محمد مروان من المانيا، واحنا بنتشرف بكل اخواننا المصريين اللي عايشين بره بنستفيد بخبرتهم، وان شاء الله هنستمر يا محمد في لقاءات معاك. صديقي العزيز استاذ دكتور احمد عثمان، يعني ضيفنا العزيز اللي شرفنا بوجوده معانا النهارده.
ميرسي يا دكتور سامح، يعني بثقه اعتز بيها، وميرسي للدعوه الكريمه طبعا ان انا الكوكبه دي كلها ان شاء الله. الحمد لله.
وعندنا خبر جميل ان الدكتور محمد مروان تفضل مشكورا ان هو هيبقى موجود بكره. بروفيسور مروان has kindly accepted tomorrow invitation to be with us at 12 noon Egypt local time on iHeart portal for a live session. هيرد على الاسئله اللي ما لحقناش نجاوبها و other questions زي a private بقى يعني session كده for those who are involved in CT. فبنشكر الدكتور محمد مروان على الوقت الثمين اللي هيقضيه بكره مع زملائنا في
محتاجه اعلان تاني دي يا دكتور سامح، يا ريت اعلان تاني.
هتنزل على الويب سايت فعلا،
يا ريت.
وبشكر طبعا شركه ماركيرل اللي هي اتاحت لنا الفرصه لهذا الويبينارز، واي هارت بمنصه اي هارت، وكل الحاجات دي ان شاء الله هتبقى متسجله وهتنزل كمان على الشانل بتاع الجمعيه على اليوتيوب وعلى الجمعيه. الحقيقه انا شايف ان دي ثروه ممكن كلنا نستفيد منها، وان شاء الله باذن الله هننزلها قريب على صفحات الجمعيه بعد ما اي هارت يخلصوا الجزء التكنيكال فيها. نشكركم شكرا جزيلا.
تصبحوا على خير.
السلام عليكم.